Dear student, today we will learn why oral rehydration solution or ORS it dramatically reduces mortality in cholera. So now we want to know how this cholera is caused. Cholera is caused by a gram-negative bacteria, Vibrio cholerae. So Vibrio cholerae is comma-shaped and it is aerobic or facultative anaerobic bacillus. So in this picture we can see the shape and size of the Vibrio cholerae. Now what is cholera? What actually happens in cholera? Cholera is a severe secretory diarrheal disease and it often occurs in epidemics associated with some natural disasters like flood, like earthquake, when the normal sanitary practices break down. So there will be contamination of water and a huge population at a time will get affected by this severe form of secretory diarrhea, and it causes a significant amount of morbidity and mortality, particularly among the young and in developing countries. Now, what is the pathophysiology of cholera? How it happens? So, as we already know that it is caused by Vibrio cholerae bacilli, which is a gram-negative bacilli, and it passes the stomach acid barrier. It passes the stomach acid barrier, and this cholera bacillus stays in the intestinal lumen, but it produces a toxin that binds to the receptor on the apical membrane of intestinal epithelial cells. So here we can see that this cholera toxin, it can bind with the intestinal luminal apical membrane, and this binding, it permits the A subunit of the toxin to enter the cell. So binding actually it happens via the B subunit, and it allows the A subunit to pass into the cell. Now the toxins, what will happen? So when the toxin is already inside the cell, this toxin will actually bind with the G protein. Okay, so the toxin binds at the adenosine diphosphate ribose to the alpha subunit of GS. Okay, so in the GS stands for the G stimulatory protein. So this toxin will bind with this subunit, that is adenosine diphosphate ribose, and it will inhibit its GTPase activity. As a result of that, there will be constitutively activated G protein, and it will produce the prolonged stimulation of the adenyl cyclase. So first this toxin will bind with this GS protein and it will inhibit the GTPase activity. Thereafter, the constitutively activated G protein, it will produce prolonged stimulation of the adenyl cyclase, and as a result of this, there will be marked increase in the intracellular CAMP or cyclic AMP concentration. Now this cyclic AMP, it will actually favor the chloride or Cl- ion secretion, and it will also prevent the absorption of sodium chloride. How it will do this? We will see here that how actually this chloride ion is secreted. Now if we look into the normal secretory method by which the chloride is secreted, so chloride uptake occurs by the sodium potassium 2 chloride co-transporter. Here we can see that it is NKCC1, that is the NKCC means sodium potassium 2 chloride co-transporter. So within the cell the chloride uptake will happen via this channel, and this chloride will be secreted, or it will exit via the cystic fibrosis transmembrane conductance regulator, that is the CFTR. C for the cystic, F for the fibrosis, then the transmembrane T, and conductance regulator CFTR. So via these, this chloride will come out, will exit the intestinal cell, and it will come into the lumen. Okay, so this is the way by which the chloride is secreted. Now, how the sodium chloride is absorbed? Now, sodium in the intestinal cells, sodium chloride enters across the apical membrane via the coupled activity of sodium hydrogen exchange. So, sodium hydrogen exchange NHE, we can see here. So, and a chloride bicarbonate exchanger, also by this chloride and bicarbonate exchanger. So, this sodium will enter. Okay, so from the lumen, this sodium will enter within the intestinal luminal cell. Okay, so what happens in case of higher adenyl cyclase activity and high production of CAMP? These two things will be changed. What will happen? So, function of this CFTR, it is increased. As a result of that, the chloride ion will be excreted out, and second thing, there will be reduction in the activity of this NHE3, that is sodium hydrogen exporter 3. As a result of that, the sodium chloride absorption, that is also reduced. So one thing is chloride is more secreted and sodium chloride absorption is less. So what will be the fate of this? As a result of more chloride secretion and less sodium absorption into the intestinal lumen, there will be huge or large volume of fluid collection, fluid and electrolyte collections within the intestinal lumen, and it will be excreted out via, it will be lost via stool. Okay, and what will happen? Sometimes the stool volume can be a very large amount, that is 20 liter per day. So we can imagine that if this amount of fluid and electrolyte it is lost from the body, so it will cause the dehydration, and that is the most important cause of high mortality of cholera. Okay, now when the sterile supplies are available, sterile water supply it is available, so these fluid can be replaced. So the treatment of cholera, it is mostly supportive. Since infections will eventually clear, although antibiotics are sometimes used, but the most important therapeutic approach is to replenish the volume lost through the stool. Okay, so this volume replenishment can be done by the intravenous fluid, but during this disastrous situation, during the time of epidemic, when huge number of patients are involved, this intravenous injection, uh, especially in the developing country, it becomes a difficult thing. Okay, so we can try here. There is a very good point about this, that the sodium and water loss can be controlled by oral administrations of the ORS or oral rehydration solution. This is a good point of cholera. So how it is possible? Now we will see that in case of cholera, the cholera toxin actually it prevents or reduces the function of NHE3. We have already seen. So the sodium chloride absorption into the intestinal lumen is prevented, and it is further increasing the activity of CFTR, so the chloride secretion is also increased. But one good point of cholera is that Here the sodium potassium ATPase pump and sodium glucose co-transporter, these two things are not affected. You can see here it can be affected by this SGLT, can be affected by rotavirus infection. Okay, now sodium potassium ATPase pump can also be affected by the salmonella. Okay, but in case of cholera, the cholera toxin, although it is affecting the function of the CFTR and the NHE3, but it does not affect the function of SGLT, that is sodium dependent glucose transporter, and the sodium potassium ATPase pump. So as the sodium potassium ATPase pump and the sodium glucose co-transporter is not affected, so we use ORS. This is a very simple, widely available packaged powder, so we can use it as per instruction. And we know that what is the constituent of this ORS according to WHO. It consists of sodium chloride, potassium chloride, disodium citrate, glucose and water. So if it is taken orally, so the sodium absorption will occur via the secondary active transport. So the mechanism of secondary active transport, we already know that in the bowel lumen, the luminal epithelial cell, it has got two surface. One is a luminal cell surface, another is the basolateral surface. So at the basolateral surface, the sodium potassium ATPase pump is working. So it is excreting 3 sodium out of the cell. So intracellular sodium concentration will be reduced. So the sodium will enter into the cell along with the concentration gradient, and during this entry it will take the glucose with it, and this will happen by this SGLT1. So although in case of any kind of fluid loss, the loss of electrolyte is mainly there, but glucose is added to the ORS solution because this glucose facilitates or enhances the sodium reabsorption within the cell. So we know that cholera toxin does not affect this sodium potassium ATPase pump, and cholera toxin doesn't affect this SGLT, and fortunately due to this, these ORS solutions can save life. So we can use the pre-packaged mixture of sugar and salt and dissolved in water, and it is a very simple remedy that has dramatically reduced the mortality in epidemics of cholera and other diarrheal diseases, especially in developing countries. Take this reference from the Ganong's Review of Medical Physiology, 25th edition, page number 463. Here I want to mention another point, that we have seen that the CFTR channel, as it is activated in cholera, so it will enhance the release or secretion of Cl- into the intestinal lumen. There is a disease known as cystic fibrosis. This is an autosomal disorder where the defective gene for chloride minus channel causes reduction in this CFTR channel in the mucosal cells of intestinal epithelium. Therefore, such patients suffer from less severe secretory diarrhea as compared to normal individual. This is also a very important explain why question. So that persons who are suffering from cystic fibrosis, they will have less severe form of secretory diarrhea because their CFTR channel is less, so chloride secretion will also be less. Thank you.